Iron levels. We might see someone who's really exhausted, but they just don't look like they're putting in the effort. So we need to look at the physical base first, see where our patients are. The thyroid, antibiotics, and PPIs, they may be on them too long, which may be causing a different gut biome to happen. It might cause overgrowth in yeast, which might cause more cravings for food. That is not a failed bypass surgery or a failed sleeve. That is called your gut's not right, and we got to fix that, right? And help them figure out why they have those cravings. Liver functioning tests might be able to help us figure out if there's any alcohol abuse going on and any kind of med changes that they have, right? So those are the things we need to look at before we say this is the patient is on their head. And that would be it. Any questions, thoughts, comments, anything you want me to field?
When you talk about delaying the surgery for some of those active kind of risk factors, what determines the 18 and 24 months? Is that sort of a national standard, or is there there are little goals in mind that you have?
Yeah, the national standard's 12 months. I go 18 months personally because I just think they need more time. We still work with them and we still set goals. So I'll make a plan together with either us and them or us and them and their therapist and say, like, here are some of the markers that we're trying to see. A lot of times if you tell somebody, like, listen, you know, I'm not happy, the drinking is just too much for this particular surgery, we need this under control, here's our plan, you know, I want you at my hungry head, I want to see this, I want to see that. They'll do that for a while until, you know, what's inspected is respected, right? Then I take the pedal off and I stop inspecting. And then I give them another 6 months or a year, and then I'll say, how did you do throughout that year? You know, and we can see, did their weight go up? Did their liver functioning tests change? Any of that. So we're looking at a bigger picture. Did their A1C come down? So we're looking at those things over time. So it's a progression of helping, monitoring, foot off the pedal, let them try it on their own, and then come back. Yeah, it's a little dance. Right. I don't think people knew we did that. I don't.
Now, you had mentioned that, I know you're going to come out with some stuff for the staff, but like almost like an algorithm of theirs, and I don't know if you have the ability to just share a couple of the things that may not concern the staff, but would concern the bariatric team, and things that might concern the staff, but would not concern the bariatric team.
Right,
Just some
right.
examples.
Yeah, absolutely. Things that don't concern the staff as much right now, that concern us a lot, is sugar. Sugar is the number one. You might think that something doesn't have a lot of sugar, or it's something that we give a patient in the hospital, like Ensure, for example. One patient had Ensure because he wasn't getting a lot of foods, and I'm not sure exactly how he got Ensure. But then he started to get very tacky, got very sick, he was dumping, right? So when the sugar goes down straight in here, you got to remember it bypassed the part of the gut that absorbs a lot of that sugar. So the body doesn't have time to process that. The sugar dumps into this part of the intestine. Then to react to that or to help process it, the body pulls in water into the intestine. They may get flush, have like a flush feeling. They might get a little tacky, the heart rate may increase, they feel a lot of pain and discomfort in the gut. It might start pulling from the sides, right? So they'll feel it differently, but those are some of the things you see. So something as simple as scanning the tray, right? Or that the little area where their friends and family bring in things for them. Because you'll be like, well, the tray was fine, or we didn't give it to them, but there may be a mix-up of sugar popsicles and regular popsicles in your floor freezer. There may be the lifesavers a good-hearted person brought into them, you know. Like, who's going to gain weight off a lifesaver? Well, you're probably not. But you're going to dump when it goes down in there, and you won't feel very good. So that's one. Sugar's a big one that we worry about that someone else might not worry about. We don't often worry about, like, a young person might have more, you know, an increased heart rate, and Dr. Sabetti and our PAs can go over this with the algorithm as well, where, you know, it just might kind of flutter a little bit and then they kind of settle down. So not to react and like, oh my gosh, you okay? And show panic, because our patient's already anxious. Remember, you got them when they're like, oh my God, why did I do this? Like, I wish I never did this. And then if we react in a panicky way, they panic more, and then you get a whole biophysical response to that anxiety, right? That could cause some other things, yeah. So not panicking is a big one over things that, you know, if it was an extended period of time, which we'll put in the algorithm, of an increased heart rate, that means something else. Heart rate, pulse, blood pressure mean a lot to, more so than like an H&H might mean. You know, Dr. Sabetti can, and the PAs can figure out a lot just from those vitals. So when the nurses call and they're really ready with all of those pieces of information, a lot can be done just off that information. It tells us a lot. Yeah. So we might not actually need additional testing, which on the floors you might think, well, why don't we do this test or give them blood? Well, that could cause more problems. So we don't want to do upper GIs if we don't have to. They're already nauseous to begin with. They just had surgery. So if we can avoid those things and use experience along the way and some of those vitals, they'll tell us more.
Do they eat low sugar for the rest of their lives?
They should, yeah. So that's actually a really good question. Initially, most gastric bypass patients are going to have a hard time with sugar, but some people, it's like a bell curve, and some people will not be able to have hardly any sugar. That's like maybe 10-ish%. Like they'll react all the time in a very negative way. Then there's about 10% of the population who do not react at all. Like they feel ripped off. I thought I was going to get dumping and it would stop me from eating sugar, but nothing happened to them. Then we have the whole other 80% where they might dump on the second bite of a cookie, the third bite of a cookie, you know, who knows? Some people can eat half a whoopie pie and they lose it on the second half of the whoopie pie, right? So it's being able to work with them and figure out, you know, what's your tolerance level, what's it doing to your weight gain or weight stability, your behavior, and then, again, managing those expectations and the goals.
And the food is always going to have to go through a dime size.
If they want to keep the value of the bypass or the surgery, if they want to keep that value, that restriction that they wanted at the beginning, then it really should be cut into a small piece the size of, or your fingertip maybe, that's another good measure, fingertip, dime size. One bite, dime size, chew it, swallow it. Not a bunch of dime sizes, chew it, and then swallow it, or else you just get that push, you know, that pressure right here of it waiting its turn to go through the hole.
But over time, can that stretch?
It absolutely can stretch, and that's where you see the weight gain.
Yeah.
So you mostly see the weight gain from in a bypass where this hole stretched. The pouch can stretch as well. The pouch is about the size of an egg when it's done. Dr. Sabetti's pouches are about an egg size. But when they stretch that opening, and they'll learn. They'll say like, oh, I just ate too much. I'm going to wait. Then they wait and it flows through. Then they do it again and again. It stretches and then suddenly they can eat what they were eating before surgery.
So when the food is delivered on the tray, is it very minute amounts?
Yeah, when you have the patients in post-operatively, they're only going to be on clear liquids. However, you know, down the road, you might have a patient come back in. Maybe they had to get their gallbladder out 2 years down the road, and they're on solid foods, right? So they need to eat in small amounts. On the floors, what you're mostly going to see is them taking clear liquids out of a medicine cup, and it should take them 15 minutes to sip through the medicine cup. And here's confusion on the floors, right, with the patients and sometimes nurses, but not so much. The patients will think, oh, is it 15 minutes? I can get 4 in. If I drink this one, I'll wait 15 minutes. I'll drink this one, I'll wait 15. But I don't get all 4 in. But then they get the pressure and the runny nose and the hiccups and the burping and the foam that comes up in their mouth. They'll often get foam that comes up and they think they're puking or there's mucus coming up. So there's been cuts here, right? There's a difference in the mucosal lining. Sometimes there's more mucus production that comes up, right? And they're spitting out this kind of latte foamy thing. That worries non-surgical nurses, like, oh my gosh, you know, there might be a little tinge of blood in it because they just had surgery, right? And they can get very, very nervous and they might feel panicky in front of the patient, where that's just kind of normal. You know, that they might need to just sip a little slower, maybe a little warmer fluid will help with that mucus production. Yes, there's little tricks that we can cover on the floors. Yeah. It's small forever. It's really the answer to your question. Yeah. Eventually, at the very end, they should be able to eat about a small amount of food, which, by the way, all of us should be eating. the portion that they are directed to at the end. All of Americans should be eating about what they can eat later down the road. I know, right? Thank you guys for listening.
Great.
Yeah, cool.
Any other questions?
Very good, thank you.
Well, thanks for coming.
Thanks so
Waking
much.
up, coming in on your day off.